CV. Yeah. So Dr. Sundeep Mishra is the Vice Chancellor of NIMS University. He is a former director, Professor of Cardiology, AIMS, New Delhi. He is the first person to do a virtual histology case in India, involved in several multinational clinical trials like the Atlas ACS2 TIMI 51 trial, published numerous articles in various reputed national and international journals, and he is editorship of several reputed journals, including the Indian Heart Journal. So Dr. Mishra is going to take us through the Guidewire Fracture Stent Dislodgement Retrieval of Embolized Materials. Over to you, sir.
Dr. Sundeep we are fortunate to have him as Vice Chancellor of University. Still he comes, so that shows his passion for teaching. I requested him. He gives very interesting talks and complications. That's why I requested him for sake of all of you. Thank you, Sundeep, for making it possible. And we'll hear from him.
Good evening, everybody. I think first of all, I have to thank Dr. Srinivas Kumar for calling me here. And it reminds me of old days when we used to be there and present, interventional cases. So I hope you are having a very good session. I think it's all efforts of Dr. Srinivas Kumar and his others, Rishi Sethi, etc. Now, it's okay. Yeah. Okay. Okay. All right. So, coming to embolizations, they are one of the most dreaded complications that you can encounter in cath lab. So, actually, previously, you might not know that previously stents were available off the balloon, and you could actually crimp them on the balloon and then you could put it in the arteries. At that time, the embolization rates were very high, but with the already pre-deployed stents or pre-crimped stents, this rate is now about less than 0.5%. Now, basically, the important thing to understand is that embolizations can happen in two places. They can happen in the coronary tree or they can be extracoronary. Important to realize, once they happen inside the coronary tree, especially if they are in the proximal part, they will be very dangerous. Even if you don't see them clotting, no thrombus formation, and you think it is okay, you cannot leave embolized material in the coronary territory, especially the proximal part. If it is very distal, maybe you can get away with it, but more or less, even if nothing is happening, if something has embolized in the coronary territory, I think you need to fix it. And we will discuss how we will fix it. The other important thing to realize is, if that embolized material is extracoronary, so most likely it will not cause any harm unless it goes to the cerebral circulation or some very this kind of artery. Otherwise, it will not cause any problem. So basically, it remains benign, and maybe you can leave it alone. There is no point in trying to fix extracoronary embolized material. So I think that is important. Now, the commonest type of embolization, as already we discussed, was the stent embolization, which is the commonest type encountered in cath lab. Okay. Now, important thing is that you have to realize that before that embolization happens, there are certain characteristics which if you are careful enough to look at, you will realize that there are higher chances of embolizations. So whenever you do complex lesions, like some of the lesions you saw, CTO bifurcations, also when there is a large angulation, when it's an angulated artery that you are doing, or a tortuous lesion, or presence of calcium, or a very distal location, or most importantly, if you have to cross a already deployed stent to pass a new stent, then that is the area where embolization is very likely to happen. So if you have a pre-stented area, be very, very careful with it. The other thing is, besides lesion characteristics, some patient characteristics are also are important, or procedural characteristics are also important. Once you go for direct stenting, there is a risk of embolizations happening. When there is inadequate lesion preparation, then there is also a risk of embolization. But most importantly, if you are unable to, there is a situation called balloon crossing, stent not crossing. And in that situation, if you try to push the stent in with some force, and then if it is not going, you try to retrieve, then this is a recipe for a certain stent embolization. So you have to be very careful once pushing a stent through a balloon part. And if it is not going, then you don't apply any force. Then, as I said, manually crimped stents have higher chance. Previous types of stents had higher chance, like coiled stent design and stents with low flexibility. So all of these were associated with embolization risk. Now, of course, once you see these characteristics, whether you see the lesion characteristics or you see the stent characteristics, then whenever you see those characteristics, you realize that there could be chance of embolization, and you be very careful with your hardware. So never use a reused material. Don't use a reused balloon, guide, or anything wire in this kind of situation. So this is another recipe for disaster. So never reuse material once you see these risk factors that I already told you. Then go for guide catheters with higher support, and go for extra support guide wires. So guide catheter should also have a higher support and extra support guide wire. Plus, pay very careful attention to the technique. So very important to prepare the lesion very well, maybe pre-dilatation, proper pre-dilatation with a proper sized balloon catheter, and if required, if it is calcium, then rota, or even use of cutting balloon. And then, very important, always remember, never deploy a proximal stent before deploying a distal stent. Always first finish the distal part, deploy the stent, and then you come to the proximal part. Because this mistake I've seen many doing, because proximal lesion is very easy to stent, and then you think that difficulties will be over, and so you stent the proximal part and then go for the distal part. Never do it. Always do the distal part and then go for the proximal part. Now, of course, once the stent embolizes, then you have to manage it. And the management depends on two important things. Number one, where the stent has embolized. As I said, whether it is coronary or extracoronary. In the coronary, whether it is proximal or distal. So site of stent embolization is very important. The other thing that is very important is the wire still through the stent? Because many times once stents get embolized, people have tendency to pull the wire, or somehow the wire gets pulled and then stent is hanging, but there is no wire. But if there is a wire, then I think that is a very important thing to know. So I think these two things help decide what and how you will manage it. Now, basically, as I said, two possibilities. One is stent is riding the wire. So I think then there are two options available. Number one is redeployment, which is the best option. Remember, out of all the options, redeployment of the stent in the correct position, if possible, is the best option. If not, then other options exist. The worst option is retrieval of the stent. That is the worst option. Many people think that, whenever things get embolized, retrieval is the basically thing to do. But always remember, retrieval is the worst possibility, because once you retrieve an embolized material, there is a huge chance that you would damage the proximal part of the coronary territory. Even left main can be damaged. So never be in this sort of situation where you try to retrieve when other options exist. But if the stent is not riding the wire, then the options are, of course, as I said, again, you try to cross with a wire and redeploy, either distally where you want to deploy, or if not, then even proximally with a high pressure balloon to achieve that size. But redeployment is the best option. The second option is crushing. And I will come to that, what you do. That is the second best option. The third best option is retrieval, or in some cases where you can't retrieve, then even CABG. So these are the 4 options that are present to you once the material embolizes. Now, this technique is very important. What you do is, when the stent gets dislodged, wire is there, you put a small balloon through that stent to the distal part, and then what you can do is slightly inflate and then try to take the stent to where you want to do. So that is called a small balloon technique. If not, then you can even go distally and pull back the stent little bit and deploy in a different part where it is easy to deploy. But as I said, deployment of the stent is the best option. This is one example. This is, as you can see, it has got 2 risk factors. One is CTO of the circumflex, distal circumflex. So one is, it is a CTO. Second is, it's a distal lesion. Third, you can see that the circumflex is arising at a huge angle. So basically 90-degree angle is there. So all the risk factors are present in this case, which could make you think that this case might have an embolization. So again, fortunately, CT was skillfully crossed. You can see the wire there and balloon with 1.5 and 2 millimeter balloon. So we can say that the operator applied the technique, is a skilled operator, and he could at least cross it and even balloon it. Now, the problem is, once you have these kind of lesions, you have to balloon it to the size of the stent you are going to deploy. You can't balloon 2 and then think that 2.5 stent can be done. It can be done in many cases, but in these, there is a risk of problems happening if you don't balloon to the required vessel size. And here is exactly what happened. The problem was, they took a 2.75 DVS, tried to cross it. So we came across this situation, balloon crossing, but a stent not crossing. What I told you is one of the recipes for stent embolization. Now, what are the options in these cases? Once you have this situation of balloon crossing, but a stent not crossing, what are the options? Of course, you can increase the guide support. You could switch to EBU or XB guide catheter, or child and mother catheter can be used. In one of the previous cases, we saw that happening. Also, you can improve the guide wire support. You could use a heavy duty guide wire, exchange to a heavy duty guide wire, take buddy wire, take buddy balloon, all these options to improve the support. And then obviously you have to better lesion prepare, because you can't just do with 2O CTO lesion, you do with 2O dilatation and you want to put a 2.75 or 3 stent, not a good idea. Now here again, what happened was, some force was applied, but there was no success. Then the operator withdrew the balloon, and you can see that a stent is proximally then sticking, which has been embolized actually, and wire has been removed, as you can see. But now this operator is very interesting. He thinks, I'll try to fix this circumflex later. Let me first do the LED. So he goes and actually, he wants to hurry and finish the case. So he puts a wire into LED and, tries to do the LED and is able to do LED because LED is a simple lesion. The problem is that while stenting, he gets into left main. So it is LED into left main stent, which has, now you can see, has also blocked the origin to the circumflex. So the stent has crossed the circumflex origin, and now you can see how difficult it has become to tackle this part of stent. And if you leave this stent here undeployed, this is a recipe for circumflex occlusion, maybe even left main occlusion. So this is the most dangerous situation. As I said, never leave embolized material in the proximal artery, ever. That is the recipe for disaster. And unfortunately, that is exactly what has happened, with very little ability to get into the circumflex now. Now, of course, the operator does all the things, but he realizes nothing can happen. The good thing is that he has this courage to call a senior operator. So he asks a senior operator to help him. And now more skilled operator is there. He's able to cross through the left main strut and then cross the circumflex stent also, which had embolized. And he knows it will be very difficult to push this stent distally because some of it might be even entangled with the left main stent. So he deploys it there at a higher balloon pressure and then takes another stent and crosses through it and then deploys distally. So this is what is done by the senior operator. The mistake was that this circumflex stent, embolized stent, was left in place and LAD was tried to be done, and this was not a good idea. So anyway, the downside is that the proximal stent may be slightly undersized, but I think this risk you have to take to keep the procedure simple and understand that perfect is enemy of good. So again, now because this is a very good operator, he knows that there is an overlap of stent in the left main. So he does a final kissing balloon dilatation. And so this speaks something of the meticulous approach. And okay, this is the final result. And as you can see, very good result finally. So, what I tried to show you was how through the case complications can happen, how you keep your cool, even call your senior or a junior even if he is more skilled, and then you get the final result, because the interest of the patient should be in your mind, not your ego. That I could not do it, why should I call anybody else? Because if you mess up with this, there is a sure recipe of disaster and person will die actually on table or outside table. So there are some other techniques also, stent recross technique, where you can partially deployed stent can be recrossed, and with a partially inflated balloon, the stent can be taken even distally sometimes, but it requires a very careful operator, very good operator. Then I think the second important technique, which is the most commonly used technique actually, as a matter of fact, is the stent crushing strategy. And this is the most commonly employed strategy. The simple thing is that once the stent gets embolized, you put another wire by the side of the stent, you balloon it, and then you put another stent from the side of the embolized stent and crush it to the side of the vessel. So that is one strategy, which is the most common strategy and most recommended strategy, which has got very low risk. Because if you can properly push the embolized material to the side of the wall and cover it with another stent, then most likely there will be no problem at all. So this is a thing, and as I already discussed the strategy, so I will not go. The important thing is, once you put the wire, sometimes wire can cross through the embolized stent and then go into the distal lumen. So to prevent that, you always put a balloon on the new wire and check whether it is going easily or not. Because if it is going through the stent strut, then balloon will get stuck and you will realize that wire is gone through the stent strut. So you re-pull the wire and again push it from the side of the stent and then take a balloon to crush it and then finally a stent to crush it. So I think this is very important to realize. I'll show another case, 63-year-old male, lesion found in mid RCA and distal RCA also, PD, and you can see, so there is a slight lesion here and distal RCA also, you can see. Now problem is distal location, and also you see the guide is not coaxial. We are looking for a good guide support. Here the guide is not coaxial. So this is, I think, an important problem that you can notice. Anyway, lesion was wired, PD was stented, and mid RCA was also stented. And then, a stent through this was taken for the distal RCA. So now I think that is another recipe. I told you, always stent the distal part first before fixing the proximal part. And so what happened was, you can see that there is a problem of this stent crossing, and actually it has embolized. Now you can see. So again, the important thing is that retrieval is generally more risky. So crush is the best technique. So what was done was, see, you can see the stent was crushed with increasing profile balloon to the side of the vessel, like here, and then another stent crossed, and then before putting the other stent, with a high pressure non-compliant balloon, dilatation was also done, and then finally the balloon was finally it was stented. And so I think also operator realized that now I have put one stent and another embolized stent has been crushed to the side, so it will be very, very difficult to put another stent into the PD. So then operator decides to leave this PD stenting, and actually operator knows where to stop. So I think that is another very important thing to know. When the things get very complicated, don't try to mess around and try to achieve the best result, because best is the enemy of good. Here it is a reasonable result, and so it was left like that. Now coming to the retrievals, as I said, they should be the last option because there is a high chance of re-embolization and also into a more proximal part and also injury to the proximal vessel. So these two risks are ever present. But many techniques can be tried: balloon catheter technique, two-wire technique, hairpin trap technique, homemade loops, small loop snares, embolised gooseneck, and other types of snares. And so I think many options are there. But as I said, this is the last option. And you can see many types of snares are also available. Just show you one case. 55-year-old male diabetic presented with class 2 symptoms, echo ejection fraction 45%, taken for coronary angiogram, revealed OM lesion proximal to with 90% stenosis and OM2 diffuse disease, and mid RC 90% and PLV another 90%. So this was the circumflex OM lesion, as you can see, and it was, you can see that there are risk factors because there are two bends actually, if you carefully notice. So this is something which is of a problem. Anyway, the patient was taken up for angioplasty and stenting, and RCA was nicely done, no problem. But when circumflex, and this is an old case, so sirolimus stents were available at that time, so it was done. But once circumflex was tried, the stent got dislodged, and there was an uninflated stent there in the circumflex, as you can see. So a 1.5 into 10 mm pre-dilatation balloon was taken across the stent, and it was dilated, and it was attempted to pull back the stent into the guiding catheter. But as I said, very difficult to pull back normally, and retrieval is not very good idea. What they have done is gone distal to the stent, inflated balloon, and pulled the balloon, hoping that stent will come out into the guide, but it did not happen. Instead, the stent got into the catheter, and you can see that the balloon is being taken through the stent, and it's there. And this is how it is done. But actually, the stent came out a little bit, but then part of the stent was in the left main and part in the aorta. So this is the most dangerous situation now. And obviously, you cannot leave it at this. So finally, you can see that this stent is hanging in the aorta, part of it in aorta, part of it in left main. So the gooseneck snare was taken, and you will see how it is pulling out this stent. So this is the stent being snared out, and finally, I mean, this is that snare, and this is the stent that you can see. This is the actual picture of that stent with the snare. And ultimately, after removing the stent, then circumflex was retackled, and this is the final result. So I think this is another case of retrieval using another type of catheter, microvena catheter. Because I'm short of time, so I will not, I think, spend much time here. What I will try to say is that management is majority of cases, retrieval is possible, but best thing is to rewire or redeploy the stent at maybe the part that you want or even the proximal part. That is the best. Second is crushing, but retrieval is the worst option. But definitely never leave the stent in the proximal coronary or in coronary circulation. If you can't do anything, then you have to send for surgery. You can't leave this patient alone. That is, I think, important thing to realize. Then there are some extra coronary embolization, and unless they are into limb, vessel, or into cerebral circulation, you can probably leave them alone and you don't do anything. Then other coronary hardware, as the wire fractures, that's also happen, and they mostly happen when you use an Oxford material, and those are the situations where they will happen more often. Other embolized hardware can also happen in different locations. Again, the principles are same. If in the coronary, you have to tackle it. If it is extra coronary, maybe you can leave alone. So, but besides the hardware, some other types of embolisms also happen: air embolism, calcium embolism, and embolization of vegetation. So for coronary embolism, what you do is IABP insertion. I think this is one way, still use of IABP. Whenever there is embolization, air embolism, it is a good idea to put an IABP because it will support the circulation for some time, 100% oxygen. Because remember, bubble has nitrogen and 21% oxygen. So if you give 100% oxygen, the size will decrease. Then aspirate, if it is proximal, intracoronary vasodilators can be given, and always heparinize the patient. So once air embolism happens, these are the things you do. If RB embolism happens, air embolism into right coronary artery, you can take a right lateral position also. Then calcium, previously calcium embolism happened when you tried to cross AS, calcified AS. Previously, it was like every AS needs to be crossed. And once people tried to cross AS, some part of calcium could embolize, and then it could go into the right coronary artery. So again, trying to retrieve will not be a good idea. The good idea would be push it distally to the most distal part and even crush it against the wall. And this is one case, and I will not show its image because the time is less, but it is exactly what was done. Through inflated balloon, that calcium was pushed distally, and then it was crushed against the side. So finally, to conclude, friends, embolizations in cath lab are rare, less than 0.5%, but can be catastrophic, especially if they occur in the coronary circulation, especially in the proximal part. Clinical importance depends on the site of embolization, whether coronary or extracoronary. Management of embolism, as I said, is largely interventional, but sometimes you might have to end up with surgery. Riding the wire or recrossing the embolized material or stent and then deploying it is the best option. But if not, then crushing is the next best. Cabbage is the last option. But sometimes, people have tried different kind of things, but I will not recommend it. Trying triple antiplatelets if it is in a side branch embolized material or in the distal part. So I think, thank you for your kind attention.